I'm Mary. I was diagnosed with myelofibrosis, primary myelofibrosis, 6 years ago, almost exactly to the date. And I was symptomatic prior to that for almost a year. And at the time, I was originally told, I had a limited lifespan, and I was actually given a death kind of year. Then 3 months into this process, I found out that I did indeed have the JAK2 mutation. And I thought back to my own father, who had a rare blood cancer in the late 1980s, and he had it for 5 years and died at age 60. In fact, we were both diagnosed at age 55, and so I felt like I was somewhat prepared for how to manage this, because I'm in the health field. I had a bird's eye view of it with my own father, and I knew how to advocate for myself, especially since my dad had to advocate at a time when there really weren't a lot of options for this cancer. But there's a lot of fear and a lot of wondering, will I be around to see my grandchildren? Will I finish out my career? Will I make the contribution to society that I had hoped to? Will I have a painful death? Those kinds of things. And I'm grateful over the years to have learned that I have so many treatment options available to me, that I don't look at the future as something grim at all. I just see it as my normal life. And that's why I'm so excited to be able to talk to other providers and other people in the industry about research and development towards not only treatment but cure for myelofibrosis.
Yeah. So what we heard here is something that's something that I hear in clinic fairly commonly, and having that fatigue, having the tiredness, is something that often takes patients or people to physicians to get tested. And there are delays. That is not uncommon either, probably because fatigue or tiredness has several reasons to it, or several possible reasons to it. Some may be more common than the others. But you also mentioned that you have the JAK2 mutation, which is of relevance here, and probably how I will start, because the basic or the premise of myelofibrosis sort of starts with the overactivation of JAK-STAT pathway, which is supposed to be a normal functional pathway, supposed to do the regular stuff and make blood cells. But when it's overactivated or activated without any restrictions, that's when things happen, or undesirable things happen, which can include affecting the bone marrow function in a negative way. So either you could be making too many cells, like your platelets were 800, which is relatively high, or you could alter the bone marrow function in the way that there is more scarring in the bone marrow, the fibrosis in the term myelofibrosis, which again affects the ability of the bone marrow to function normally, which is its job to make normal quantity and quality of blood cells. And as a result of that, patients can get anemic or have low hemoglobin, which can cause the tiredness and the fatigue and difficulty breathing and symptoms related to that. The other piece of things that can happen is, again, by virtue of the JAK-STAT pathway activation, is this systemic or generalized inflammation piece of this that we often notice or have patients, lead them to a workup. And what that results in is what we in our clinic call as constitutional symptoms, or symptoms that are, again, could be non-specific or vague as sometimes labeled. But those can include things like night sweats, things like low appetite resulting from, or other symptoms resulting from an enlarged spleen, abdominal discomfort, and so forth, which are, again, other symptoms that can sometimes lead to further investigations clinically.
So, myelofibrosis, as Dr. Jain put very nicely, is a stem cell derived blood cancer, and it can affect people in different ways. And one of the things I think is really important to impress upon the audience is really you don't meet two people that walk the same path. They all really come in different forms and fashions. Their clinical picture can be really varied, and then their course can be quite heterogeneous and variable too. So you really have to sort of understand the patient that you're dealing with and what might be those patient-specific goals of therapy. For some patients, it could be alleviation of anemia. For other patients, it could be the systemic symptoms, the fevers, the night sweats, the weight loss, the bone pain, the profound fatigue that can be quite debilitating. And for many patients, it could be this enlarged spleen or liver that's really causing a lot of discomfort and challenging just normal activities of living, like bending over and doing things that would normally be easy to do. So sort of knowing how the disease is affecting the patient really informs and dictates how best to approach the patient. So it's typically trying to alleviate the symptomatology and reduce the spleen, and that's usually using JAK inhibitors. And over the years that we've grown to have 3 clinically or commercially available JAK inhibitors: ruxolitinib since 2011, fedratinib since 2019, and pacritinib since 2022. And those cytokine-driven symptoms that Dr. Jain explained are a result of this JAK-STAT pathway. So these drugs are great in reducing a lot of that inflammatory cue that makes patients feel terrible and awful, and improves their sense of well-being, their functionality, reduces their spleen so they can eat more comfortably and wear pants more comfortably, things that we kind of take for granted. And in doing so, I think patients have a better quality of life and will, by virtue in most cases, live longer because they can do the simple things that we need to do. They can move and they can eat, and people who move and eat will simply live longer and do better than patients who cannot. And that's just generally true in oncology. So they have really revolutionized, I think, particularly the quality of life aspect. And I think we have a great armamentarium today that covers lots of different types of patients to improve the symptoms and improve that quality of life. And we are developing drugs now that are looking to try to improve anemia. So historically, we use drugs like Procrit or Aranesp. These are erythropoiesis stimulating agents to try to improve hemoglobins, get patients out of the transfusion suite, give them some more energy back, or drugs like danazol, synthetic male androgen, or even drugs that we repurpose, which is a common theme in oncology, repurpose from other diseases like multiple myeloma. We use drugs called IMiDs or immunomodulatory drugs, like thalidomide or lenalidomide or even pomalidomide. And these can all be used in myelofibrosis off-label, I will point out, to improve hemoglobin with responses of about 20 to 30%. So the reality is we can improve hemoglobin in some patients, we can improve symptoms and spleen, but there's still really a lot left to do. And I think that's when I say I'm optimistic that work that we collectively do, that Dr. Jain, myself, and many other dedicated clinical investigators do, really makes I think the future bright and exciting.
I was just going to say, Dr. Mascarenhas, you answered my next question, but could you tell us a little bit about how those JAK inhibitors work, and then walk us through not only the ones that are available, but what are their benefits and limitations?
Sure. So JAK inhibitors are a class of agents, actually, interestingly, invented in the setting of this disease, and now actually have applications through a lot of different diseases that are not even malignant. And what they do is they intermittently reduce the signaling pathway Dr. Jain was explaining that is inappropriately activated in the bone marrow cells. And this pathway is responsible for causing proliferation of blood cells and elaborating inflammatory mediators, and they intermittently quell this cascade of events, and that reduces the propensity to have this inflammatory state and this overproduction of blood cells. And what that seems to do is improve symptoms by reducing cytokines, which are these inflammatory byproducts. Patients feel better, and patients can move and eat, and restores vitality. For reasons that I personally don't understand, and I've never seen a good explanation for, it also reduces the spleen. It's sort of a phenomena I don't really understand why. It's really an interesting aspect of the drug. So we know it reduces spleen, it reduces symptoms by reducing the activity of this pathway. Unfortunately, what it does not do, any of these drugs do in the JAK-STAT pathway inhibition class, is they don't induce remissions. They don't kill the what I would call the maternal stem cell, the grandmother cell that gives rise to all of these abnormal cells. It doesn't get rid of that cell. So it really kind of quiets down what's happening in the bone marrow and the spleen, sort of allows for some degree of normalcy, but the malignant cell population still remains, in the body, in the bone marrow and in the organs. And unfortunately, we don't see changes in the bone marrow that would, lead us to believe that we've remitted the disease. So the disease kind of sits there. Myelofibrosis is in the name. You have scarring in the bone marrow that typically remains, even while patients are enjoying the clinical benefits of the drug. And then there's the potential for downsides of the drugs. I mean, they often will exacerbate cytopenia. Cytopenias are low blood count. So anemia and thrombocytopenia, low hemoglobin, low platelet count, can often get lower with these drugs. We've sort of pivoted to try to develop drugs that may not be as myelosuppressive as count reducing and may even improve some of the blood count. So pacritinib, approved last year, is a drug that can be delivered in patients with low blood counts, less than 50,000. And in about 25% of patients can improve the hemoglobin. And momelotinib has also been associated with improvements in blood counts. And what we now know, which we didn't know when we started off in all of this, is these drugs are not just JAK inhibitors. They're actually very dirty drugs. They are kind of promiscuous. They interfere with a lot of different pathways that may be relevant and irrelevant and cause toxicity. So, for example, inhibiting ACVR1, which is another pathway that's important for iron availability, might explain why pacritinib and momelotinib improve hemoglobins, and why maybe ruxolitinib or Jakafi and fedratinib or Inrebic don't. And so there's a lot of nuances with these drugs that help us understand why they may fit niches and help certain people in certain ways, and why you can provide serial JAK inhibitors. So if you fail one, it doesn't necessarily mean that you wouldn't enjoy some response to another. So one can go from one to the other. And I think the tailoring of the JAK inhibitor really is somewhat of an art, not more than a science in some cases, and requires, again, what I would say, is knowing the patient, knowing what the goals are, and trying to match the potential goals and potential toxicities to that patient.
Thank you for that. And I've often heard that we're not getting rid of our JAK2 inhibitor, but we're maybe turning the volume down on it a bit with the use of these drugs. And it leads me to a question to you, Dr. Jain, is how do you know which JAK inhibitor might or might not work and which one to try first for a patient?
Yeah, that's a great question. And I'm going to sort of piggyback on what Dr. Mascarenhas was alluding to, and emphasize on the point that he said that no two patients with myelofibrosis will be the same. Everybody will have their own presentation, or a different presentation, or different things that you'll need to address or improve in a particular patient. And everybody will have a different trajectory in terms of the course of their disease, course of their myelofibrosis. And that is what is important to recognize as you're thinking about what you're going to start a patient on in terms of what your choice of JAK inhibitors is going to be. So a lot of times I tell my patients, we don't have the same treatment for everyone. We're looking at what we need to address in you as a patient. So, for example, if there's someone where we're trying to address high counts, perhaps a JAK inhibitor makes sense, or if they will usually have a big spleen and symptoms or symptoms that will need to be addressed in combination with that. And for such a patient, a JAK inhibitor would make sense. Usually, probably based on the fact that we have the longest experience with it, ruxolitinib or Jakafi has been sort of our first go-to. It was, the first approved about a decade ago, and we sort of feel more comfortable with it. We know how to sort of, dose adjust it, and we sort of know how to, move things around with it. If that doesn't work, then the go-to next step in an ideal world would be a clinical trial. Obviously, clinical trial, even in a first-line setting, but something after Jakafi, in an ideal world, would be a clinical trial. But if we do not have one that would fit, would be either fedratinib or pacritinib, and the choice would depend on where the blood counts stand at this point. So, for example, if the platelets are on the lower side or the cell counts are on the lower side, pacritinib would probably be a better choice. Obviously, there are patients who do not have spleen or symptoms as a major presenting thing, and anemia is a major presenting thing. And in those situations, as Dr. Mascarenhas alluded to as well, options such as Procrit or danazol, and hopefully momelotinib, pacritinib to some extent are some of the options. Luspatercept is in clinical trials. We'll see how that pans out. So those will be some of the options. And then the third set of patients is those who come with a more advanced disease in the way of more excess or higher fraction of blasts or leukemic cells or very, very early cells in the bone marrow that indicates that these patients are perhaps headed towards a leukemic transformation or headed towards the pathway of a more aggressive pattern of disease like leukemia. And in those situations, either in combination with JAK inhibitors or without, something like hypomethylating agents could be considered, usually en route to a bone marrow transplant, if that makes sense otherwise in terms of eligibility. But those are some of the scenarios that one would think of as we encounter patients with MPNs.
Let's talk about single drug therapy. There's a new drug, momelotinib. What patient might it benefit?
Sure. So momelotinib is a JAK inhibitor. So it's much like ruxolitinib Jakafi, except as I mentioned before, there's some nuances that make these drugs a little bit different. So it also inhibits ACVR1, which is another pathway that regulates iron availability for red blood cell production. So really in its long development history, it's really differentiated itself from the other drugs in large part by its ability to improve hemoglobins in a subset of patients. And I would encourage patients to discuss with their physicians if that drug might make sense for them, or any of the other drugs that we've talked about, whether it's fedratinib or ruxolitinib or pacritinib. And I think as we've said, it really has to be tailored to the patient. So although I'm excited to see momelotinib come up, and for a physician, it's great because it gives us different options. So for the patient, different options. For the physicians, it also allows us to tailor the treatment for each patient.
What are the best drug combinations at present? Can you introduce us a bit to combinations in drug therapy?
So I'm not sure if I can answer what is the best drug combination right now, but I think that is a question that hopefully we will learn more and more about and hopefully address in the future. But there certainly are drug combinations that are promising, which, in the clinic means that it brings options for patients, options that we can offer to patients, mostly on a clinical trial right now, but certainly some that hopefully will move the field forward. So the sort of basis of this is that historically we have addressed the JAK-STAT pathway, right, which we have learned the most about in the last couple of decades, and that probably is the primary pathway involved in the pathogenesis or the occurrence of myelofibrosis. But as we have learned more over the years, there are other pathways which may not be primary, but certainly critical to the development of myelofibrosis. And that is where the rationale for drug combinations comes in. And we've seen several clinical trials in the last few years that have addressed that or used combination therapy in patients who are not having a good response to Jakafi itself and need more than that. Many of those drugs have been tested even in first-line setting to see if people or patients would do better with combinations up front rather than Jakafi alone, which has been the long-standing go-to first-line treatment for over a decade now. Some of those pathways, some of the drugs that you'll hear about, navtemadlin, for example, which is an MDM2 inhibitor. Dr. Mascarenhas presented that data at EHA a few months ago. Showing responses in about 1/3 of patients. Depends upon how you define a response, but 35% spleen reduction in about 1/3 of patients in patients who weren't responding to Jakafi or ruxolitinib itself. There are BET inhibitors like pelabresib that I heard Dr. Mascarenhas actually talk about at ASH, which also is now being tested in the first line in patients who are starting upfront treatment. There's BCL-XL inhibitors like navitoclax, which have shown some improvement in second-line setting, and we're awaiting public announcement on the data for first-line trial. And there are others, right? So the premise is that you're combining two mechanisms that you that have shown to work in this diagnosis, and you're trying to combine drugs such that you do not have overlapping toxicities, right? So that's an important piece to remember as well, because JAK inhibitors can have, can cause some decrease in blood counts, or at least we've seen that with ruxolitinib. And you probably want to add a drug that may not do that as much, or may not do that to an extent that makes it prohibitive of a combination. Then, for example, with pacritinib, patients often would get sort of gastrointestinal toxicity. So probably don't combine a drug that may also have gastrointestinal toxicity. So I think that's important to remember as we think about combinations, which we will see more and more coming up in the future.
Thank you so much, Dr. Jain. Dr. Mascarenhas, if you would just follow up with what should patients ask when considering a combination therapy that, like Dr. Jain just talked about, and how do we know when it's right or the right time to start one?
So I think that probably the first question to ask is why this combination for me? Like what would be the advantage in my case in terms of addressing goals of therapy? And then importantly, what are the potential risks? So, as physicians, I'm definitely included when I say this, we often focus on the positives and focus on what we think is going to be the advantage of participating in a clinical trial. But the reality is that sometimes, there are disadvantages, and there can be toxicity associated with approved drugs and unapproved drugs that are in clinical trials. So I think what patients want to understand is what would be the goals for them personally in participating in this trial in terms of expectations of results, and what are the potential known or in some cases, if it's an early trial, potential toxicities that one could incur, and then what does the patient need to be aware of as they go along in the trial in terms of mitigating and reporting. I think a trial is not really a passive experience. It's actually a very active experience where the patient is an active participant, not simply receiving a drug, but has to be very willing and engaged to report all symptoms, not to report what they think might be important, but to report everything to the study team, and that might sometimes mean calling ahead of their visit to let the team know what's going on, and making sure that all their medications are accounted for, and that they're following up, because it is an opportunity to assess whether a drug is active, but also to adequately characterize the toxicities of a drug, so that as the drug moves along, perhaps for patients in the future, that it's optimized in the delivery for those patients. So it's really two objectives. One is, how is this drug going to help me, and what is my role in this whole process? Because it really should be a joint venture. It's not a one-sided experience, and we learn from the patients. Hopefully, the patients also learn. The patient community learns from what we're doing, and everyone benefits.
Thank you, Dr. Mascarenhas. If I may, Dr. Jain had set up really well the sort of landscape of the combination therapies and talked about different options. And maybe we can start with selinexor and a JAK inhibitor. I think a lot of these are JAK inhibitor plus maybe a novel drug or.
So I think the first thing to point out to the listeners, and I always try to make it a point when I'm seeing patients in the clinic, is that clinical trials today are unlike, I would say, in large degree, what clinical trials were historically. And what I mean by that is these drugs are all rational with preclinical data that supports them, and they are, they go through enormous amounts, and people don't always realize this, enormous amounts of testing through various aspects before they ever enter a human being. So there's an enormous amount of regulatory burden that exists. That's really annoying, but really important to do, because it provides that certain sense of confidence in the investigators, but also in the patients, that what we're introducing makes sense, that we're not just taking something off the counter and saying, I wonder if this is going to work, and throw it, into a clinical trial. So these are rationally developed drugs. So example is selinexor. So selinexor is a really interesting drug. It's a drug that's already approved for blood cancers that are not myeloid cancer. So blood cancers on the other side of the fence. So these are diseases like multiple myeloma and other B-cell lymphomas. And this drug is a drug that affects the shuttling of proteins in different compartments in the blood cell, in the nucleus and the cytoplasm. Selinexor is a great example of a drug that affects multiple pathways that really induces the myelofibrosis, perhaps even stem cell population, the primordial cells, to undergo this process of death. And it works best in combination with ruxolitinib. And that's a common theme that we've seen, is that in oncology, it is very rare, except for maybe CML or some other diseases, where we use monotherapies. In most of oncology, we use combinations of therapies to synergize together, and as Dr. Jain said, to try to avoid overlapping toxicities, but synergize for efficacy to get deeper responses. And that's what we're seeing with drugs like selinexor or navtemadlin, which is a great wealth of data at this point, demonstrating that these drugs are active as single agents, but they seem to be even more active in combination. And this is supported by studies that are done in mice that are engineered to have myelofibrosis. And that's where a lot of this comes from. And in primary cells, from people that have been generous to donate their blood cells in the clinics at tertiary care centers. And we take those cells and we experiment, we figure out how are we going to make better drugs in the future. So I thank those patients who give it seems like a small thing, but it's a huge aspect of how we move this whole machine forward in clinical research. All of that information allows us to say, hey, look, this combination really looks effective. Well, we've got these JAK inhibitors that are already commercially out there. We're going to add this drug that synergizes nicely in these preclinical models and these cells in the dish, and we think it's going to work better than each drug alone. And we'll figure out how to dose them and schedule them to minimize toxicity. And that's really where we're seeing it. So we're seeing selinexor, we're seeing navtemadlin, we're seeing pelabresib, the BET inhibitor, navitoclax, the BCL-XL inhibitor. All of them really look good in combination with ruxolitinib. And as Dr. Jain said, ruxolitinib, because that's really been around the longest, and that's sort of the go-to drug that we combine drugs with. And what we're seeing is we're not even waiting anymore for patients to have failed, the first line of therapy. We're introducing the drugs earlier on. We get confidence in their ability and their toxicity profile, and we say, well, why wait? Why wait for patients to do worse? Why not try to get deeper responses earlier on? And I think the punchline here is we're looking for deeper responses. The deeper we can reduce the disease burden, we believe that the better the patient will be overall. Not simply feeling better in smaller spleens, which is important, but less disease cells in their body will hopefully mean longer progression-free survival, longer overall survival. So navtemadlin, selinexor, pelabresib, navitoclax, and imetelstat. There's a whole host of drugs that are aiming to really hit the clone and induce deeper responses.
Just on the note of transplant, because that is such a huge topic for so many people and they hear so much about it, in the context of the landscape changing so quickly, do you feel that you and other specialists in the field will be recommending transplant less to people? And I know this is probably a very individual response, but just as an overall high level look with everything happening, what's the trend there?
Well, I actually think of it the other way. I think we have, by virtue of having more effective treatment strategies to improve spleen and symptoms and get a disease response, we may be perhaps able to take more patients to transplant as a more curative therapy later on. A lot of times, for example, lack of spleen response or poor performance status by virtue of a lot of symptoms or disease advancement into a more aggressive disease pattern headed towards leukemia and things like that, they become, in fact, barriers to transplant. And I think having more options in the future will allow us to take more of these patients to transplant. I mean, we've seen a lot of advances with a lot of these options. What we have not seen so far as such, and hopefully we will in future, is sort of the curative potential. I mean, all of these drugs have a lot of advantage in terms of improving spleen, symptoms, cytopenias, but So far, we have not had definitive improvement or getting rid of the abnormal stem cell clone. And that's something that, at least so far, we only achieve with a stem cell transplant. So at some point, as long as patients are eligible for transplant, and that is something that would fit their life wishes in general, that would be a consolidative or a potentially curative option to consider. And I think more treatments or better treatments, better non-transplant treatments will only get more patients to something more curative like a transplant.
If there's one thing or, one top message you'd like for our audience of patients and care partners to walk away from, what would that be?
I think hopefully to share my enthusiasm and optimism that we are making advances and that there is a brighter future, and that I'm really genuinely excited about that, and to embrace the opportunity of clinical trials. That clinical trials sometimes are looked at as for other people, but they may actually be important for you, and to talk to your physicians. And you may not go through with it, but learning about it, I think, and exploring it is important for each patient.
I think I'll sort of add to that to say that it's never a wrong time to see a specialist or to see someone else if something is not working out. I mean, as Mary said, that some of the symptoms didn't really come out as being very specific, but being an advocate for yourself and getting a few things done, or maybe seeing another doctor or getting a second opinion, as maybe. Never hesitate to do that. I'll also pitch in as a transplanter. I also am obliged to pitch in that getting an opinion about transplant and at what course in your disease that may make sense is an important question to address. You don't have to wait until you're progressing or not responding to drugs. I think that question needs to be addressed and outlined in an early appointment rather than waiting for too long.
Just sitting in on this conversation, continue to have hope, continue to want to thrive and live. At the beginning of my journey with myelofibrosis, I was told I'd be dead by age 72. And that was only 6 years ago. And now they're saying you could outlive this. You could die with this, not of it. And hearing both Dr. Jain and Dr. Mascarenhas talk today about all these combination therapies and how they actually might get us to the cure was very exciting for me. Thank you.